All right, so we're going to start now coverage improvements during the transition period. This is HR Advanced Webinar Series Healthcare Reform number 5, March 15th of 2013. I thought what we would do to start off things, because we're going to be dealing with this in and out through the material, is reviewing the essential health benefits that were issued via regulation from Health and Human Services earlier, actually late last year, beg your pardon. And there's 10 categories, and so the plans that will be on the exchanges will have these essential benefits. Plans that you have to qualify, if it is not a grandfathered plan, and a grandfathered plan, just by way of reference, is any plan that was in effect on or before the date that the law was signed into, the act was signed into law. That was March 23rd of 2010. So if you've made any substantive changes to in plan design to your plan after 2010, which seems like an eternity ago, you no longer have a grandfathered plan. And what that's going to mean is that you're going to have a plan that will have to at least provide these 10 pieces here. Now, I'm not going to read them through. You probably have already done that as I've been talking. But these are pretty much the kinds of things that we tend to see in plans. Now, there are some things in here that we're going to talk about in the slides that is going to come up in fairly cryptic language that is talking about what's not in here. For example, one of the things that you don't see in here is critical illness, certain cancer treatments. That's not to say that that's not going to be covered. It's not to say that somebody who has that's going to be out of luck. It doesn't mean that. It just simply means that it is not an essential health benefit. Those are just a couple of examples. I mean, if we were to sit and kind of kick this around a lot, we find that there's a lot of things that are not really essential health benefits that we take for granted, but the government does not. And so that'll come into play. Group health plans and health insurers offering group health or individual insurance coverage are prohibited from imposing lifetime limits on the dollar value of benefits for any participants and from imposing most annual limits on essential health benefits. Let's talk a little bit about that kind of a long sentence there. First of all, we started to see this a long time ago in healthcare reform, and we're seeing it all the time now, and that is group health plans or individual insurance coverage. Group health or individual. Traditionally, these have been two types of policies that have really never met. ERISA governs group health. Individual plans are governed by the state because they're all going to be insured plans, obviously. And so they really have owned their own separate rules. One of the things that healthcare reform is doing and has done is sort of melding group health and individual coverage. Now, that may be good, that may be bad. Let me take a stab at where that perhaps is an opportunity for some of you employers that are on this call here. Group rates, it's been my experience that group rates on health plans, and I own this company where I work here, so I have to make these kinds of decisions. Group rates were much more expensive than individual rates with very good coverage, substantially more expensive. And so one of the things that we did at our company was we took a look at what a group plan would cost, and we found out that we could be more cater to individual desires and wants of our employees by offering them individual plans. We would say we're going to put up 80% of the cost of the plan, which is very nice employer payment. And they'd be responsible for the 20% above that on the premium side. And we picked out pretty much a standard plan of what it would cost. And we compared that to what a typical group health plan would cost. And we found that the individual market just was so much more competitive. Now, that's going to vary by state, obviously, but the fact that healthcare reform is looking at these as really kind of more like the same thing now makes it at least worth the time. If you have, I don't think I'd want to administer a 300-life company with individual plans, but if you have a smaller company, and most of the people that are on this call probably have smaller companies, that's been my experience, you might want to look at individual plans, because under healthcare reform, they're going to be one and the same. They're going to be one and the same. So group health, individual, doesn't matter. They're prohibited from imposing lifetime limits on the dollar value of benefits for any participants, and from imposing most annual limits on essential health benefits. Okay, we looked at the essential health benefits. That's what this is applying to. It's applying to that. It does not apply to non-essential health benefits. So if there are some benefits that don't exactly fall into those 10 categories, you're not obligated to impose this rule. Now, when we talk about imposing lifetime limits and dollar value on benefits, it seems like for those of us that have been in this for a little while, we've sort of seen this before. And the place that we've seen this before for the first time was in 1996 with the passage of the Mental Health Parity Act. Now it's got some big long name and substance abuse and some politician in there. And all. Anyway, it's the same thing. And it's been sunset. But basically, as you all know, mental health parity requires that you cannot have, let me rephrase that, if you have a lifetime or an annual limit, dollar limit on non-mental health benefits, that same limit at least must apply to mental health. Okay, that's the rule, so we've had that for a long time now. Well, they're saying the exact same thing here as it applies now to not only mental health, which is one of the 10 categories of an essential health benefit, but they're saying that rule now applies to all 10 categories, which is basically pretty much 90% or so of what's going to happen to all of us when we need health care from a doctor. So that is prohibited under essential health benefits. No longer can you have lifetime limits or dollar value caps on the benefits. Now we have, of course, the inevitable exceptions. A plan may exclude all benefits for a condition. Now that may seem very contrary to what we're trying to do, which is to provide, more access, more health care, and things like that. One of the goals of health care reform. But there it is. So if you have a plan and you want to exclude benefits for a particular condition. Now, what that, for example, you couldn't like say, well, we're not going to cover hospitalization. That's not what they mean by that. What they mean is, for example, within a certain category, there might be a particular condition that you say, well, you know what, for whatever reason, actuarially or something else, we're not going to cover that condition. That could be kind of spooky. I think that's going to be challenged for a change, but that is the rule. So if, for example, if you had a condition and you said we are not going to cover, I know this sounds horrible, diabetes. That's a condition. It's a chronic condition. So is glaucoma. So is depression. Now depression you'd have a problem with because the state mandates we get involved. We'll talk about that later. But anyway, that's what they're talking about there. Within a category, a specific condition, you can exclude for all benefits. So there's no benefit for that condition. Now, you might get a lot of blowback from your employees, which I would be prepared for, but the law allows you to do that. A condition-based exclusion is not considered an annual or a lifetime limit. Okay, so if you have a condition that you're eliminating from your plan, that is not considered that you've like dropped the annual limit or you've made it out of reach. No, it's not even counting that. Is what they're saying. That it doesn't apply anymore here. Number two, on the exceptions here, a plan or an issuer, which would be an insurance company or a third-party administrator, can still place annual or lifetime dollar limits with respect to specific covered benefits that are not essential health benefits. So it all kind of comes down in our talk today to essential health benefits. Things that are not considered essential health benefits, the same old rules that have been around for decades, at least when it comes to lifetime or annual dollar limits, still apply. So if you have a benefit that's not within the essential health benefits category, those 10 categories, you can, and the insurance company probably will, unless you want to pay more for it, place an annual or a lifetime dollar limit on a non-essential health benefit. And that is to the extent that such limits are otherwise lawful under federal or state law. Now, mental health is one of the 10 essential health benefits, and I guess probably in every state in the union, the states have different ways that they approach the kinds of mandates that you have to comply with when it comes to mental health. So there might be it might be more complicated when you start looking at that particular piece specifically, because in all 50 states there are rules that relate specifically to the provision of mental health. So you might want to just take a look at that and talk to your broker in the state that you're in. Number 3, it remains lawful to improve limits on benefits that are not dollar limits. Well, of course, everybody likes that. Number 4, the restrictions on annual dollar limits do not apply to HRAs that were in effect prior to September 23rd of 2010. So if you had an HRA coupled with a high deductible health plan, and you had that up and running before September 23rd, these annual dollar limits, as specifically relates to the HRA, do not apply. They do not apply. Lifetime limits. If an employee or a beneficiary lost coverage due to a lifetime maximum dollar limit prior to the effective date of the regulations, but is still otherwise eligible for coverage, the plan must notify. Okay, there's a notification requirement there that you have to do. The plan must notify, that would be the administrator who's physically the person who has to do that. The plan must notify the individual in writing. Now, I don't think email is going to suffice. I have not read that it does, but anytime when they say in writing, they're usually talking via the mail and sometimes certified mail. But you have to put that notification in writing. You can't just verbally convey that. And what that has to say is that the lifetime limit on the dollar value of all benefits no longer applies, and that that individual, if they're covered, is once again eligible for all benefits. Okay, so here's a person who exhausted their lifetime maximum. Wow, this person had some bad days in their life because they went right through that big top number. And but because now, if they're in the if the lifetime max was for an essential health benefit, which is going to cover most of them, then the plan must say, well, you know what? That has been lifted, so you now requalify for your entire benefit plan through the company or through an individual plan, same thing. And the plan administrator has to notify that person in writing that, hey, listen, you know, I know you got kicked off because you blew through the $1 million mark or the $2 million cap, or, you know, lifetime cap, but, you know, that is gone. And that's in 2013. That's right now. Actually, the limit right now, let me rephrase that. The limit right now is going to go up next year, but the limit right now is $2 million. So if you've got somebody that has blown through $2 million on your plan, it probably doesn't cover hardly anybody, but it's a possibility. You now, in 2013, have to notify them in writing that, come on back, get on the plan. And they have to be given at least 30 days from the time that they get the written notice to enroll back onto the plan. Annual limits. Prior to January 1 of next year, group health plans and health issuers offering group health or individual coverage may impose restricted annual limits with respect to the scope of benefits that are essential health benefits to the extent permitted by HHS. Well, that's kind of a lot of gobbledygook there, but basically what we can knock off the what's permitted by HHS because they've already said that that is permitted. So that's, we can boil this thing down a little bit. So this year, your plan, or if you have an individual plan for your employees, you can impose a restricted annual limit on the benefits, and that includes essential health benefits. That's up to January 1 of 2014. Now, perhaps you were aware of this rule already because it's been around for a while, and maybe you did this, and that might be a good thing for you. But I realize that we're getting late in the hour, and so here we are on March 15th. The open enrollment for the exchanges kicks in October 1, so we're, good grief, we're 6 months, 7 months away from that right now, 7 months. So perhaps this is a day late and a buck short, but if you have that in your plan and you're wondering, well, gee, how can I still do that? The answer is yes. You can do that up to January 1 of 2014. Now, there's with regard to these limits, I mentioned that there was a $2 million cap, an annual limit that is currently out there. Actually, I think I said a lifetime limit. It's actually an annual limit. And there were other numbers here, but they were for last year and the year before that, so I thought, well, that's really old news. So there was this 3-year phased-in approach on annual limits restrictions. And so since we're in the 3rd year, because it all kind of starts really in January, for this year, any plan year that began after the 23rd of September 2012, but before the end of this year, December 31st, the minimum annual limit on benefits is $2 million. You can have a higher number, but you can't have a lower number. So if your plan has a lower number for any plan year that started after September 23rd, 2012, so this is going to hit everybody sometime this year because there's more than 12 months between September 23rd and December 31st, 2013. All of you should look at your plan. You would be out of compliance if your annual limit is less than $2 million. That's the take-home value on that one. Now, only essential benefits are taken into account in determining whether an individual has received the applicable amount. So this $2 million cap annually for 2013, it only applies to the essential benefits, those 10 categories that were on the very first slide. And once again, if you joined us late, you can download this entire PowerPoint presentation by clicking on that tool that came on Go to Training, and you'll see a thing called Materials, and you'll see a link there. It says it's the HR Series 5. That is this PowerPoint presentation. Okay, dollar limits. Now the regs restrict the impact of annual dollar limits with respect to essential health benefits. We've already established that, but they keep repeating this. I guess they really want us to get the message. So the annual dollar limits only apply to essential health benefits, the 10 categories, the very first slide that we looked at. Now the regs are silent. They're silent with respect to limits based on the number of visits or treatments or pre-procedure dollar limits. So it seems that it's still lawful in 2013 if you have a plan, or it probably wouldn't be practical to change your plan because you're going to have to change it again on January 1 of 2014, but I guess you could do that, short plan year kind of a thing. But for things that are for medical treatments or doctor visits that are not part of essential health benefits, you can put in some of those controls like the number, the dollar limits on how much we're going to spend on chiropractic, for example, which is an age-old bugaboo. Or we're going to limit the number of visits that we have to the chiropractor. We'll pick on chiropractors today. So we're going to put a dollar limit on how much you can spend off the plan on chiro, and we're going to limit the number of visits to a chiropractor to whatever, some number. And you can do that. That is lawful this year. That's all going to change next year, but for right now you can do that. The annual dollar limit restrictions do provide that Health and Human Services may establish a program. So they're giving themselves an out, which probably means that there might be something coming down the pipe. They may establish a program to permit individual limited benefit plans. Now, there was a lot of talk a couple of years ago about these mini-med plans. They were very popular. They were very popular, and they're still out there, but a lot of them kind of went away when it looked like they were going to be outlawed by healthcare reform. And mini-med plans, you see a lot of these in like in retail establishments, fast food places, for example. Oftentimes they'll have these mini-med plans where they're a mini-med plan, and they just don't apply. They have some benefits, but they're extremely truncated, very limited in what they offer. But at least there's a benefit out there, and the thinking is totally out of sync with healthcare reform to offer these kind of cheap, chintzy plans. That was not the plan. The plan was to offer full benefit plans. That's what people wanted. That's politically what was happening. But the mini-meds, there are some rules out there that they did survive, but they're restricted in terms of how they can be designed and how they can be administered to the plan participants. Anyway, these mini-med plans, HHS in fact did issue some regs that to apply for a that allows employers to apply for a waiver on the restricted annual dollar limit if such plan can demonstrate that the compliance with the annual dollar limit rules would result in either a significant decrease. Okay, I'll stop right there. It's just way too wordy. Let me explain what this is talking about. Now, a mini-med plan is going to cross over the 10, maybe not all 10, but it's going to cross over some of the 10 essential health benefits. I don't know how you could not do that and call it a medical plan, a health benefit plan. So because of those essential health benefits, we know that with the essential health benefits, as we've already discussed on this call, that the annual or lifetime dollar limits, they're pretty much going to go away. And they're already very high. So there's a conflict between these mini-med plans, which have low annual and lifetime limits, and what, in fact, the law says under ACA, essential health benefit plans that cover those 10 categories, what those limits will be. So how are we going to reconcile the two? Well, HHS said that we understand there's a lot of employers out there that this is basically the only thing they can afford, or whatever the rationale is. So you can apply for a waiver. So if you're an employer and you're in that position where you've got a mini-med plan and you're going like, okay, I'm hearing this thing loud and clear, dollar limits, lifetime limits going away, mini-med plans are full of those things here. How can I get around that? Well, the way you get around that is you call HHS, you contact them, they got a form, you can apply for a waiver, and that would allow you to keep that plan in place. And hopefully that's a lot clearer than the gobbledygook that we just went through there. Non-essential health benefits, non-essential benefits. A group health plan or health insurance issuer offering group health or individual insurance coverage may impose lifetime or annual limits on coverage of specific benefits that are not essential health benefits, or exclude all benefits for a condition. Okay, now this is in there, and it was sort of like in the context of the law, but it's like I think we've already pretty much said that and beat that one to a pulp. But that's the rule. So non-essential health benefits, you can exclude conditions if it's not a non-essential health benefit, and you also can impose lifetime or annual limits on non-essential health benefits. Now that doesn't leave you a lot of room to be perfectly candid, because those 10 categories pretty much cover the whole gamut, but not everything. All right, I'm going to go through this part really quick because I realize that it doesn't apply to probably most people on here. But I do know that there are some people on here because they called me ahead of time. And so we're going to go through these student health plans here really, really quick. And if nothing else, it's kind of like if you're not overwhelmed already, well, maybe this will do the trick. But that's not the point why we're trying to do this. March 12th of 2012, Madam Secretary Sebelius and her team issued a final regulation that addressed insured student health plans for colleges and universities. Now, here's kind of the skinny on that. The student health plan must be provided by a college or university through an insurance contract, not self-funded. Self-funded plans are not in the scope of this rule. So a student health plan has to be governed by the state and offered through an insurance company. And that's that. Number two, coverage availability must be limited to enrolled students and their dependents. That's it. So a very limited scope in terms of who's eligible. Number three, students or their dependents cannot be excluded on the basis of a pre-existing condition, or other health status factor. So, but we've known that, actually. I mean, we've known for a number of years now that pre-ex is applied to any plan participant under the age of 19. And since a lot of students fall into that, although some now are a little bit older than that, in their early 20s, but that's what they're saying here. So if you've got a student health plan, regardless of the age, that plan cannot apply pre-ex, no pre-ex. Preventive care must be provided without cost sharing, i.e. co-payments. No cost sharing on the preventive care side. So for women having tests that women have on the preventive side, and for men having tests that men have on the preventive side, keeping in mind that this is mainly for college and university students. So some preventive tests for older people may not apply. A college or university can continue to charge a student a health fee to help offset the cost of operating a student health clinic. So no cost sharing, but there can be like a flat fee that the clinic at the university or college can charge the student, and that is considered lawful. There can be no lifetime limits on essential health benefits. Well, there's the clarion call on that one here. Okay, let's talk about some account-based plans. Here's the background. I'm just going to kind of leave this up here and maybe just kind of talk about it, because I know usually you folks don't like it when I just read the text, but sometimes that's the message. But in this case, it's not. This is, you know what these things are. Let me just read the very first line there. And then, because it kind of applies to the rest of the stuff then. The prohibition on annual dollar limits for benefits under a group health plan does not apply to account-based plans. Now, these are health flexible spending arrangements, MSAs, savings accounts, health savings accounts, or health reimbursement arrangements. So this is sort of the background on where the law does apply and where it doesn't. Standalone, this last one here, standalone HRAs remain viable for retirees. Okay, well, fine, because the ACA does not apply to a retiree-only plan. Okay, now we're going to start dealing with some of those prickly issues that deal with children and pre-ex under age 19, and then for dependents up to age 26 and before they turn age 27, and how all of that works. So this might be a refresher for you. There might be some new points that you're going to pick out, but it's pretty much the whole enchilada here. The Affordable Care Act generally extends the group health plan prohibition on pre-existing condition exclusion provisions to the individual market. So individual plans, all that pre-existing condition stuff that we see coming, and which is going to be eliminated on January 1. There will be no pre-existing condition exclusions, January 1. It's going to be costly, but from a policy point of view, that sounds like a pretty good thing. We all know that that's been kind of a thing of job lock, even though HIPAA tried to take a stab at that back in the 1990s. However, the Affordable Care Act accelerates the prohibition for enrollees who are under age 19 for plan or coverage years beginning after September 23rd, 2010. You guys all remember that. That was the time when that law went into effect that states that any dependent who's age 19 or below cannot have, there's no pre-existing condition exclusion that can be applied to those people. So kids and adolescents, no pre-ex ever since September 23rd of 2010. Now, no coverage or enrollment limitations may be imposed regardless of the child's previous coverage status. Now, if you don't know that rule by now, then we are a little bit late to the game, but I still love you in a professional way. But that is something you should have known. Okay, the Affordable Care Act requires that any group health plan, and we're talking about preventive health services, which has been controversial. Any group health plan or health insurance company offering group or individual health coverage must provide at a minimum. You can do better than this, but you can't do less. And you can't do it without the and you must do it without the impositions of any cost-sharing requirements. And what you're providing is coverage for specific items or services in 4 separate and distinct areas. Now, this coverage mandate does not, however, apply to grandfathered health plans. So if you're fortunate enough to still have a grandfathered health plan, and the grandfather's pretty much dying off every day in the country, but if you're fortunate, this does not apply to that. Here's how the rule goes. Number 1, the preventive health benefit must cover all evidence-based items or services that have in effect a rating of A or B in the current recommendations of the U.S. Preventive Services Task Force. Now, I must admit to you that I am not really sure what that means. There's not a lot about that I've been able to find on the U.S. Preventative Services Task Force and their rating system, but that is it, and that's the rule. Number 2, the preventive health benefit must cover immunizations for routine use that have in effect a recommendation by the ACIP or the Centers for Disease Control with respect to the individual involved. Okay, so on that preventive stuff, it has to cover immunizations that are authorized by CDC and the ACIP, specifically as it relates to that individual. So if somebody's in an age bracket and these are recommended immunizations for that particular age bracket of person, male or female, because they're going to be different, those immunizations would be covered under the preventive health care rules of ACA. Number 3, the preventive health benefits for infants, children, adolescents must include preventive care and screenings in the guidelines set forth by HRSA. And that kind of goes in concert with point number 2. The last point here on this slide, the preventive health benefit for women must also include any other preventive care and screenings set forth, again, in the guidelines by HRSA. Sorry for this long, kind of small piece of text. It was one complete thought, and I didn't want to break it up here, so I know it's a little difficult to read, but I know that part of the value that a lot of you see in this is the PowerPoints themselves. Health and Human Services, Treasury, DOL, those are the big 3, issued interim final regulations on September 17th of 2010. And those rules sought to clarify the manner in which certain preventive care benefits should be provided under group health plans without cost sharing. And here's how they shake down. For both in-network and out-of-network benefits, there is no requirement that free coverage for preventive benefits be extended for benefits provided out-of-network. Okay? So basically, preventive care came into play, and what maybe we didn't know is that if you have a PPO or if you're in an HMO, you're probably in a PPO, that free coverage that was touted as a big deal at the time, what the part that they didn't really talk about, but you're hearing now, and maybe you knew this, but maybe you're hearing it for the first time, is you do not have to pay free. You don't have to cover the coverage free for preventive care that's out of network. So if a plan participant goes out of network and goes to see doctor or whoever, and they're not in the network, it's not free. Number two, if any item of preventive care service which is required to be covered without cost sharing is billed separately from the office visit, a lot of moving parts in this one here, then the plan or issuer can impose cost sharing with respect to the office visits. Okay, let's kind of break that one down. Now, an office visit, you go in the doctor, it's a CPT between $99,200 and $99,215. That's it. So if you ever get an EOB and they say what happened, and you look at the current procedural terminology code, an office visit is anything between $99,200 and $99,215. That's it. Now, we would normally, you and I, when we go to a doctor, we go to the doctor for a checkup. We're going to get on our EOB, if I know those are, you don't see too many of those around anymore, but the coding of that particular episode of care will be between $99,200 and $99,215, and it's based upon time and complexity of the visit. The longer the time and the more complexity, the higher the number, the higher the cost. That's how that works. Now, the reason I went a little bit deep in the weeds on that part here is to say that most of the time when you and I go to a doctor for, it hurts when I do this, or my arm hurts, or I got a sore throat, or whatever it might be. The doctor's going to look at you, and as part of that office visit, he's going to, or she is going to say, okay, this is what's wrong with you, and why don't you go and drink some soup and watch TV, or a couple of Tylenol will do the trick, whatever. It's usually not, a lot of times more than that. So all of those services are billed as one thing, the office visit. It's not like they itemize out, well, what was wrong with him or her. It's just an office visit. $99,200, $99,215, and every number in between. Now, if that's what is happening when a patient goes to the doc, then, and it's for preventive care, for example, okay, I had my PSA checked. I hope it's not too much information for you. Men age 50 and over are supposed to have their PSA checked, although there's some controversy about that now. Now, I had this done back in November, and I went to the doctor for a checkup. I do this every year, and the doctor, took the little hammer and hit me in the leg, and knocked around on my back and made me cough, all that stuff. We've been through that. All of that is an office visit. The only thing that was not required in that particular office visit, him sticking his finger up, you know what I'm talking about, and was the PSA was a blood test. And so he says, you got to go over to the lab for that. Okay, well, that is not, that's a separate issue. It's a separately billed issue because that's a separate profit center for the clinic, the lab. Now, they then send the results back to my doctor, and my doctor calls and says, hey, your PSA is 0.0 whatever, which is good. All of that was covered under, that is a preventive care item, and all of that would be covered under the cost of the office visit, except for one thing, and that is the venipuncture, which when they take the blood and get it analyzed. Okay, long part on number 2 there, but I wanted to make that point clear. So this covered preventive health services is only free if it's 1, in-network, 2, covered as part of the office visit. Got it? Good. Number 3, if an applicable preventive care service is not billed separately from an office visit and the primary purpose of the visit is the delivery. Now here, the primary purpose is the operative phrase here. What are you really going there for? What's your plan participant really going to the doctor for? If the purpose of the visit is the delivery or administration of applicable preventive care service, well, then the plan or the insurance company cannot impose cost sharing with respect to that office visit. It's free. That one's a freebie because the purpose of the visit was exclusively for preventive care. Now, in the process of the conversation, something else might have come up, and that maybe led to say, hey, listen, I think, you got that ache in your ear or something. Maybe you should go see the CNT guy that's down the hall there, make an appointment with him. Well, okay, there's no charge for him telling you that, but that could lead to another visit. But that the purpose of why you went there was not to say, by the way, I've got this thing here. That was an afterthought. The purpose was for the preventive care. If that's the case, no cost sharing. Number 4, if an applicable preventive care service is not billed separately from an office visit, and the primary purpose of the visit, here's the opposite of the previous. If the primary purpose of the visit is not the delivery or administration of applicable preventive care, then the plan issuer can, of course, they can impose cost sharing because it's no longer, the reason is no longer preventive health care. That might be ancillary to the reason why you went there, but what was the primary reason why you went there? I think you guys get the picture. Okay, 1, 2, 3, 4, 5. A plan issuer is free to impose cost sharing with respect to other preventive care services that are not applicable preventive care, and may also impose cost sharing in the event that a covered preventive care service is no longer an applicable preventive care service. Boy, I have to say it how many times. However, any such changes that permit cost sharing to be reimposed must be administered consistent with the general requirement that a material modification in coverage must be perceived. All right, here's what they're saying there. They're saying that things may change. Things do change. Things change on what's considered preventive care. Things are added in terms of preventive care. Right now, I mentioned PSA. One of the things there with PSA is they're saying, well, maybe you don't have to have that so often. Colonoscopies, okay? We're supposed to have a colonoscopy when we get to be a certain age. Well, now some of the thinking that's coming out is that maybe we're having colonoscopies too often. And unless you have something that they see in the colonoscopy that might say, well, we want you back in 3 years, maybe they should go 10 years or later. They're questioning the efficacy of that. Not to mention the risk that you could have, a problem, that could occur, anytime they have an invasive procedure like that. So anyway, when those things change, and they change the rules of what is considered a preventive care services, here's what you guys have to do. Number 1, you got to put it in your plan. Now, because it's a change in the plan, this rule is saying that that plan is a material modification. Material modification. Well, that is a trigger for Title I of ERISA, reporting and disclosure. You have to issue then a summary of material modifications under the plan to the plan participants. And it has to be at least 60 days advance notice before you can enforce the rule. Got that? So if these preventive care services change, the government is saying that that's considered a material modification in the plan. That triggers an SMM, summary material modifications. And you must issue that, and it cannot go into effect for at least 60 days after the notice. Last point here on this long, long page. A plan or issuer may impose cost sharing with respect to a treatment that is not applicable preventive care service, even if the treatment results from an applicable preventive care service. Okay, I guess we could probably just already read that one. Women's contraceptive service, very, very controversial and very heated here. So I hope we don't get any questions on this one because I don't want to get beat up by everybody, because whatever I say, I won't be able to satisfy everybody. Let me first say that on this particular issue, in dealing with this issue in your company, there really are two issues here. One is the pure health issue of women's contraceptive services. I'm certainly not questioning that, and I don't think many people do. I know there are some, but most people I don't think do. What is a larger issue, though, that sort of came along for the ride is the religious freedom. And that's how this thing has been attacked when the administration first announced it. It really was, and for some reason they chose to look at Catholic, not churches, but like schools and charities and things like that that offered benefits, and said you have to offer contraceptive services. And they said, well, wait a minute, for us, you're making us do something that violates our faith. Okay, so that becomes a religious rights issue. And so when you're dealing with this issue in your company, at least be aware of that side, that sometimes people are not coming at it from a purely rational medical point of view. They're coming at it from a religious freedom, saying, how can you, this is terrible. We're on a slippery slope. The world's going to pot, that kind of thing. Having said all that, HRSA was charged with developing comprehensive guidelines for preventive care and screenings for women that would be covered under PPACA compliant non-grandfathered plans. Okay, only applies to non-grandfathered plans. And policies without cost sharing in the following areas. So no cost sharing for you ladies that go for well women visits, screenings for gestational diabetes, the human papillomavirus test, counseling for sexually transmitted disease, counseling and screening for HIV, human immune virus, breastfeeding support, supplies, and counseling, which obviously you have a right to that as well, and in the workplace, as I'm sure, hopefully all you know that, ladies. Screening and counseling for interpersonal and domestic violence. Okay, kind of more of a behavioral side of the healthcare. And then contraceptive services, with the exception of religious providers. Now, the religious provider thing goes like this. It's narrowly defined. It's narrowly defined. Has the institution to satisfy the safe harbor, which means they do not have to include contraceptive care or medications of pills and things like that in their plan. They have to have an inculcation of religious values as their purpose. 2, they must primarily employ persons who share the religious tenets of that organization. 3, services primarily persons who share the organization must service primarily people who share the religious tenets of that organization. 4, the organization must be a nonprofit organization and described as described in the IRS. That would make them a 501c organization. Okay, that's what a nonprofit is in the code. That is who a religious provider is. Now, if you satisfy that, and some of you might fall into this category, then it goes on. Now, while maintaining the narrow religious employer exemption, Health and Human Services issued a bulletin establishing a 1-year temporary enforcement safe harbor for group health plans. So all that heat that we saw on the cable channels, it's gone now, but it's going to come back again because it's only for 1 year. Remember, people are looking at this as a infringement on their religious rights. They're not looking at the medical side of it necessarily. And I'm not taking a position on that, by the way. So the safe harbor for group health plans for nonprofits, and they do not provide some or all of the contraceptive coverage otherwise required because of the organization's religious beliefs. The safe harbor went into effect for the first plan year that begins on or after August 1 of 2013. Okay, so that's it. No action will be taken against group health plans or health insurance companies that meet the following basic requirements. Number one, well, you know what? We didn't have to even read these. You can read these pieces here. They're a little bit different, but they're also kind of in keeping with the previous slide that defined really what is a religious organization that qualifies for the safe harbor. Okay, extension of coverage for children to age 26. We're just about done, guys. So just so you know here, so don't hang up on me here. And I know a lot of you want to get your PHR credit, so you need to be on for an hour, and we will finish almost exactly at 1 hour. Affordable Care Act requires all group plans, health plans, and all health insurance companies offering group health at a group level or individual health policies for dependent children to continue to make that coverage available to kids up to age 26. Now, there was some, at least to me, there was some controversy. Is like, okay, if the person's 26, what if they're married? What if they got a kid? You know, a child? How does that all work? Well, that's all cleared up here. It's only for the person. So if you've got one of your children is has not turned 27 and they're younger than that, your child can stay on your plan. However, the plan does not have to cover if they're married. If your child is married or if your child has children, your plan does not have to cover that. They only have to cover your child as a dependent. Number two, it amends the code, the Internal Revenue Code, to make the extended dependent coverage a pre-tax benefit for any employee or deductible for self-employed taxpayers. And all that's saying is that health care is not included in the adjusted gross income of the employee. And that's, now they're saying for the dependents, that's all they're saying there. Now that covers dependents as well. It is pre-tax, it's not part of their gross income, they'll never see it on their taxes. Number three, the Act provides for a high deductible catastrophic coverage option for adults under 30. Now this might be a new one for a lot of you. This high deductible catastrophic coverage option for adults under 30 participating in the exchanges beginning in 2014. So if you feel that you're really healthy, and if you end up on the exchange, or your employees end up on the exchange next year, there will be a catastrophic coverage option that will not necessarily fulfill the spirit of the essential health benefits, but if you really are down for the count and something terrible has happened to you, you'll have this high deductible catastrophic plan that you can buy probably at a relatively lower rate. And it'll be for adults under 30. Don't know why they picked that number, but that's the number. Interim final regs interpreting and extending coverage requirements announced that surcharges for children under age 26 are not allowed, except where surcharges apply regardless of the child's age. So under 26, you can't mark up the premium. No surcharges. When you got one that's under 26, we're going to charge you an extra $50 a month. No, you can't do that. They're dependent just like they were when they were 5 years old. Lastly on this slide, the value of medical coverage or reimbursement for medical expense provided by an employer to its employees and their spouses and dependent children is treated tax-free compensation for employees for federal income tax purposes. Now you notice it doesn't say state income tax purposes. that is something the states have to take up. In Wisconsin, where I live, just to give you an example of how crazy that can be, our previous governor, now it sounds like I'm getting political. I'm really not. I'm just stating a fact. But Governor Doyle, one of the last things he did when he was in office up until, I don't know, 3 years ago or something like that, he was one of the, I think he was the last state in the union to hold out on providing tax-free the distribution of assets to pay for medical care for an HSA. Now, all the other states in the union had already said, you know, okay, you're paying for medical care. I mean, come on, it's sort of, that should be tax-free. You shouldn't have to pay taxes on that. Well, Wisconsinites had to do that until really just a few years ago. Now, that's what this is going to say here. So you're going to have to find out at the state level whether or not this, for these dependent children, it's tax-free compensation for federal, but not necessarily for the state income tax, if you have a state income tax. Now, the ACA amends the code, that's the Internal Revenue Code, to extend pre-tax treatment for employment-based health coverage provided to adult children of an employee up to a calendar year in which the child reaches age 29. I think we all knew that rule. Okay, I'm going to leave this one here for your enjoyment here, and a couple other things on transitional relief, because I'm looking at the time and we want to keep on the time. So I'll take some questions if you have some questions at this point. Otherwise, you can certainly reach me and at either of these email addresses, and I'd be more than happy to be prompt in getting back to you. If you do have a question, just raise your hand, and then I can call on you. I'll see if there are any hands raised. And I was either so thorough or else I was so confusing. We don't really have any questions down here, at least not that pertain to, you know, the content. Okay, one more pass here, see if there's any questions, hands raised. Okay, we're just a little bit over an hour. 2 minutes over the hour. How's that? 62 minutes. So I want to thank you all for participating in this this HRCI webinar on healthcare reform, and I look forward to tell your friends, and if you find this useful, and also for getting credit, or if you just want to gain the knowledge, because we'll be doing these at least through May, and probably a little bit longer, because some of the content we're finding is just way too much to deal with in 1 hour. Thank you, everybody, and I look forward to talking with you soon.